Now, I mentioned the distinction between a coexistent pseudoaneurysm and AV fistula and a combined pseudoaneurysm and AV fistula. This is an example of a combined pseudoaneurysm and AV fistula. The image to the left shows a typical appearing pseudoaneurysm, but when you look at the flow pattern in the neck of the pseudoaneurysm, it is not the to and fro pattern. It's a high velocity, relatively low resistance pattern with lots of antegrade diastolic flow throughout the cardiac cycle. This is the type of a pattern more consistent with an AV fistula, and this suggests that this pseudoaneurysm has some sort of outflow other than the neck. As we looked a little bit more closely, we did find this outflow tract right here. And waveforms obtained from the outflow tract again show low resistance, high velocity flow consistent with an AV fistula. So the anatomy here is like this. There is there's a pseudoaneurysm arising from the femoral artery, but then it connects to a channel that drains into the femoral vein. So injection of this pseudoaneurysm would result in thrombin just spilling directly into the vein, potentially causing DVT or PE. Now, why do you get combined pseudoaneurysm and AV fistulas? If you look at the anatomy of the common femoral artery and vein, you can see that there are a number of small branches, and several of these branches, one is shown here, go in front of the femoral artery. So this is a venous branch that travels in front of the femoral artery. If you puncture right in this area, you can potentially get an AV fistula between the artery and that venous branch, and if there's also a pseudoaneurysm involved, then that produces a combined pseudoaneurysm and AV fistula. That's the sort of thing that you would not want to inject. Okay, let's move on to the next clinical scenario. What do you do when a patient with primary hyperparathyroidism has a negative Sestamibi scan and a sonogram that shows suspicious nodules or nodule? And here's our index case. So a Sestamibi scan shown up above is negative. Ultrasound shown below shows a small nodule, deep and along the inferior aspect of the right lobe of the thyroid, and then a similar size nodule, more superficial and inferior to the left lobe of the thyroid. So in this situation, do you trust the Sestamibi scan and assume that the nodules are lymph nodes and not parathyroid adenomas? Do you trust the ultrasound and diagnose multi-gland involvement? Do you recommend an MRI or a CT to further evaluate these nodules? Do you recommend aspiration of the nodule or nodules? Or do you recommend angiography with venous sampling? Well, in this case, we decided to aspirate the nodules. The nodule on the right was relatively deep and would have been hard to get to. The nodule on the left was superficial and relatively easy to get to. So we aspirated the nodule on the left, and we sent the specimen for PTH assays. And you can see that the result of that assay was a PTH value of 4.9 picograms per millimeter. That's within the normal range, indicating that this nodule is not a parathyroid adenoma. Knowing that, we assumed that the nodule on the right was the parathyroid adenoma, and this patient went for a right neck exploration, and sure enough, a right superior parathyroid adenoma was identified in a posterior inferior location, just as we would have predicted. So let's talk a little bit about aspirating parathyroid nodules and sending the specimen for PTH levels. This was first described, as best I can tell, back in 1994 by a group at Beth Israel and Harvard. The technique that they used was they injected 0.25 cc's of saline into the nodule and then aspirated as much of that fluid as they could. They did it one or more times. They put the specimens in separate tubes, froze them, sent them to the lab to get PTH assays. And in their experience, most of the ones that were positive were unequivocally positive. In other words, the PTH levels were quite high. although they did have 6 parathyroid adenomas that had false negatively low PTH levels, and presumably that was because they did not adequately sample the lesion. They did not describe what levels of PTH they obtained in the lesions that were not parathyroid adenomas. Now, since this time, a number of institutions have started to do this, and in fact, in busy practices, it's fairly common procedure. This report from the Cleveland Clinic describes doing 1 to 2 passes, diluting the specimen in 5 cc's of saline. In other words, they do a couple of passes, they aspirate what they can, they put the aspirate in a tube with 5 cc's of saline, submit that for analysis. And in their experience, the positive results range between 44 and 13 million picograms per ml. And 91% of their positives had a value greater than 500. In lesions that were not parathyroid adenomas, the values range from 4 to 15. And in this last study, more recently from a group in Istanbul, had a fairly similar technique. And in their experience, the positives ended up having levels between 3,700 and 5,000, and the negatives had levels between 4 and 20. The technique that we use at Mallinckrodt is to aspirate a suspicious nodule with a 25 gauge needle. We use suction. We take the sample and wash it with a cc of saline and inject the resulting mixture in a test tube. Then we put the test tube on ice, and then we repeat the aspiration and wash the needle and the connecting tube with saline from the prior aspiration. And then we deliver it immediately to the lab for analysis. And here's some examples of other cases that we've done. As you can see above, there's 2 ultrasounds showing a complex solid and cystic mass inferior to the thyroid with readily detectable internal flow. The Sustamibbe scan in this patient was negative. Because this was such an unusual appearance for a parathyroid adenoma, we thought that we wanted to be sure that that's truly what it was, so we aspirated it, and you can see the result was greater than 4 million picograms per milliliter. We consulted our charts, and in fact, that was above the normal range. And this turned out to be a complex parathyroid adenoma. And here's the last case. This is a patient, again, with primary hyperparathyroidism. In this case, the Sustamibbe scan was positive, showed an area of persistent uptake in the region of the left lobe of the thyroid. On the SPECT scan, you can see that it clearly looks like it's arising within the left lobe. And they described that as increased accumulation in the left lobe of the thyroid and gave a differential of either a thyroid adenoma or a parathyroid adenoma. So we went on and did an ultrasound on this patient, confirmed that there was a solid nodule in the left lobe of the thyroid, quite vascular on color Doppler imaging. And in our opinion, we thought that this was more consistent with a follicular thyroid neoplasm than a parathyroid adenoma. Given that potential differential, we decided we needed to aspirate this nodule, and the cytology from it came back as follicular cells in a background of blood. So this was in fact a follicular lesion. Unfortunately, cytology cannot distinguish a follicular thyroid nodule from a parathyroid adenoma. You can only do that with PTH aspirations. So in this case, the PTH assay showed a result of greater than 2,000, and we felt comfortable calling this a parathyroid adenoma, and in fact, it was intrathyroidal parathyroid adenoma confirmed at surgery.